Okay, this is beginning our part 2 of our pain management chapter from the Lewis book. The World Health Organization has developed pain management by mouth, by the clock, or by the latter. To maintain freedom in pain, drugs should be given by the clock, which is every 3 to 6 hours rather than on demand. This 3-step approach of administering the right drug in the right dose at the right time is inexpensive and 80 to 90% effective. Acetaminophen is the best first choice medication. The principle of start low and go slow is used to guide therapy when treating elderly adults because the ability to metabolize medications is decreased and the likelihood of medication interactions is increased. Non-opioid analgesics are used for mild to moderate pain, although opioids may be used later. Keep in mind that aspirin and nonsteroidals are associated with a high incidence of gastrointestinal bleeding in elderly patients. Adjuvant therapy are used in conjunction with opioids and non-opioids, generally developed for other purposes, but also effective for pain. Corticosteroids. These drugs include dexamethasone, prednisone, and methylprednisolone, and are used for management of acute and chronic cancer pain, pain secondary to spinal cord compression, and inflammatory joint pain syndromes. The mechanism of action may be due to the ability of the corticosteroids to decrease edema and inflammation. Because of this effect, corticosteroids are useful when injected epidurally for acute or subacute disc herniations. Antidepressants. Tricyclic antidepressants enhance the descending inhibitory system by preventing the cellular reuptake of serotonin and norepinephrine. Higher levels of serotonin and norepinephrine in the synaptic cleft inhibit the transmission of nociceptive signals in the central nervous system. They appear to be effective in a variety of pain syndromes, especially neuropathic pain. Anti-seizure drugs affect both peripheral nerves and the central nervous system. Agents like gabapentin, lamotrigine, pregabalin are valuable adjuvant agents in chronic pain therapy and are being used increasingly in the treatment of acute pain. GABA receptor agonists. Baclofen is an inhibitory neurotransmitter and interferes with the transmission of the nociceptor impulses and is mainly used for muscle spasms. It crosses the blood-brain barrier poorly and is much more effective for spasticity when delivered intrathecally. Alpha-2 adrenergic agonists. Currently, clonidine and tizazidine are the most widely used. They are thought to work on the central inhibitory alpha-adrenergic receptors, and these agents may also decrease norepinephrine release peripherally. They're used for chronic headaches and neuropathic pain. Local anesthetics. For acute pain from surgery, local anesthetics like bupivacaine or ropivacaine can be administered epidurally by continuous infusion, but also by intermittent or continuous infusion with regional nerve blocks. Topical application of local anesthetics are used to interrupt transmission of pain signals to the brain. An example, 5% lidocaine patch is recommended as a first-line agent for the treatment of several types of neuropathic pain. In the treatment of chronic severe neuropathic pain, oral therapy mexiletine may be tried if pain is refractory to other analgesics. Mixed mu agonist opioid and NE5-HT reuptake inhibitors. Some analgesics have 2 distinct actions or dual mechanisms. Tramadol is a weak mu agonist that inhibits the reuptake of norepinephrine and serotonin. It is effective in low back pain, osteoarthritis, diabetic peripheral neuropathic pain, polyneuropathy, and postherpetic neuralgia. Tampenadol, it acts via mu opioid receptor and also by inhibition of serotonin and norepinephrine reuptake. Cannabinoids show promise in the treatment of certain pain syndromes and symptoms, but these preparations have sparked considerable controversy. Synthetic cannabinoids like jorabinol have been approved for medical use in Canada, the United Kingdom, and the United States. Administration. A patient should be premedicated before painful procedures and activities that are expected to produce pain. Similarly, a patient with constant pain should receive analgesics around the clock rather than on an as-needed basis. Titration is dose adjustment based on the assessment of analgesic effect using the smallest dose possible to provide effective pain control. An analgesic can be titrated upward or downward depending on the situation. An example is a postoperative patient. A dose of analgesics generally decreases over time as the acute pain resolves. On the other hand, opioids for chronic severe cancer pain may be titrated upward over the course of therapy to maintain adequate pain control. The goal of treatment for chronic pain usually is to enhance function and quality of life. Generally, oral administration is the route of choice for a person with a functioning GI system. Most pain medications are available in oral preparation, such as liquid and tablet formulations. For opioids, larger oral doses are needed to achieve the equivalent analgesia as doses administered intramuscularly or intravenously. For example, 10 milligrams of parenteral morphine is equivalent to approximately 30 milligrams of oral morphine. The reason larger doses are required is related to the first-pass effect of hepatic metabolism. This means that oral opioids are absorbed from the GI tract into the portal circulation and shunted to the liver. Partial metabolism in the liver occurs before the drug enters the systemic circulation and becomes available to peripheral receptors or can cross the blood-brain barrier and access CNS opioid receptors, which is necessary to produce the analgesia. Sublingual and buccal, opioids can be administered under the tongue or can be held in the mouth and absorbed into the systemic circulation, which would be exempt from the first-pass effect. Although morphine is commonly administered to persons with cancer pain via the sublingual route, little of the drug is actually absorbed from the sublingual tissue. Instead, most of the drug is dissolved in saliva and swallowed, making its mechanism the same as that of oral morphine. The transdermal route, like fentanyl, is available as a patch for application to non-hairy skin. This delivery system is useful for patients who cannot tolerate oral analgesic drugs. Absorption from the patch is slow and it takes 12 to 17 hours to reach full effect with the first application. So a transdermal patch is not suitable for rapid dose titration, but it can be effective if a patient's pain is stable and the dose required to control it is known. Patches may need to be changed every 48 hours rather than the recommended 72 based on an individual patient's responses. Parenteral routes include subcutaneous, intramuscular, and intravenous administration. Single, repeated, or continuous dosing is possible via parenteral routes. Although it is frequently used, the IM route is not recommended because injections can cause significant pain, resulting in unreliable absorption, and with chronic use can result in abscesses and fibrosis. Onset of analgesia following subcutaneous administration is slow, and a subcutaneous route is rarely used for acute pain management. However, continuous subcutaneous infusions are effective for pain management for end-of-life care. This route is especially helpful for people with abnormal GI function and limited venous access. PCAs are best for controlling acute pain, and if a patient is on an epidural pain medication, urinary retention is a common side effect of epidural opioids. Headaches are not an anticipated side effect of morphine, although if there is a cerebral spinal fluid leak, the patient may then be developing a spinal headache. So sedation could be a possible side effect, hypotonic bowel sounds, and constipations would be a concern. It's important for the nurse to monitor the respiratory rate, because that may indicate a need to decrease the PCA dose or change the medication in order to avoid further respiratory depression. Interventional therapies. Nerve blocks are referred to as regional anesthesia, and this includes local infiltration of anesthetics into a surgical area, like chest incisions, inguinal hernias, joints, injection of anesthetics into specific nerves like occipital or pudendal nerve plexus like a brachial or celiac plexus. Adverse effects of nerve blocks are similar to those with local anesthetic that are delivered by systemic route, and that includes dysrhythmias, confusion, nausea, vomiting, blurred vision, tinnitus, and a metallic taste. Temporary nerve blocks affect both motor function and sensation, and typically last 2 to 24 hours depending on the agent and the site of injection. Motor ability generally returns before sensation. Neuroablative techniques are used for severe pain unresponsive to other therapies and destroy the nerves to stop transmission. Destruction of nerves is accomplished by surgical resection or thermocoagulation, including radiofrequency coagulation. Neuroablative interventions that destroy the sensory division of a peripheral or spinal nerve are classified as neurectomies, rhizotomies, and sympathectomies. Neurosurgery procedures that ablate the lateral spinal cephalic tract are classified as chordotomies if the tract is interrupted in the spinal cord, or tractotomies if the interruption is in the medulla or the midbrain of the brainstem. Neuroaugmentation, there have been advances that allow the use of multiple leads and multiple electrode terminals to stimulate larger areas. The most common cause of spinal cord stimulation is for chronic back pain secondary to nerve damage that is unresponsive to other therapies. Distraction works by helping the patient ignore or become unaware of pain. Pleasurable sensory stimuli may also release endorphins that help relieve pain. Different non-pharmacological approaches will vary depending on the pain and the patient. Massage is a common therapy for pain, and good evidence supports the use of massage for acute and chronic pain. There are many different massage techniques, including movement of the hands or fingers over the skin slowly or briskly, superficial, firm pressure, or trigger point massage. A trigger point goes around a hypersensitive area within a tight band of muscle. It is caused by acute or chronic muscle strain and can often be felt as a tight knot under the skin. Trigger point massage is performed by applying strong, sustained digital pressure, deep massage, or a gentler massage with ice, followed by muscle heating. Exercise is a critical part of treatment plan for patients with chronic pain, particularly those with musculoskeletal pain. Research supports the effectiveness of many types of exercise for a variety of painful conditions, and many patients become physically deconditioned as a result of their pain, which in turn then leads to more pain. Exercise enhances circulation and cardiovascular fitness, reduces edema, increases muscle strength and flexibility, and enhances physical and psychosocial functioning. Distraction involves redirection of attention away from the pain onto something else. It's simple, but it's effective. It can be achieved by engaging the patient in activity that can hold their attention, watching TV or a movie, conversing, listening to music, or playing a game. Hypnosis. Hypnotherapy is a structured technique that enables a patient to achieve a state of heightened awareness and focused concentration that can be used to alter the patient's pain perception. Research supports the effectiveness of hypnosis for many types of acute and chronic pain. Relaxation strategies. Relaxation strategies reduce stress, decrease acute anxiety, distract from pain, alleviate muscle tension, combats fatigue, facilitates sleep, and enhances the effectiveness of other pain relief measures. Relaxation strategies include relaxation breathing, music, imagery, meditation, and progressive muscle relaxation. Nursing and collaborative management. The nurse acts as a planner, educator, patient advocate, interpreter, and supporter of a patient in pain and the patient's family. Support the patient and caregiver through the period of trial and error that may be necessary to implement an effective therapeutic pain. It's also important to clarify responsibilities in pain relief, and you can help the patient understand the role of the members of the healthcare team as well as the roles and expectations of the patient. Barriers to effective pain management are common concerns of tolerance and physical dependence. Tolerance occurs as the bodies adjust to pain medication and requires higher doses to produce the same pain relief effect. Tolerance occurs with chronic exposure to a variety of drugs. In the case of opioids, tolerance is characterized by the need for an increased opioid dose to maintain the same degree of analgesia. Addiction is a complex neurobiological condition characterized by a drive to obtain and take substances for other than the prescribed therapeutic reasons. Threshold is the minimum amount of stimulus that elicits the pain. Analgesics elevate the pain threshold. Then dependence is the expected physiological response of ongoing exposure to a pharmacological agent that shows withdrawal symptoms when blood levels of that medication are abruptly stopped or decreased. Tolerance and physical dependence are not indicators of addiction. So the risk of developing addiction is associated with certain factors like a younger age, personal or family history of substance abuse, and mood disorders. The risk for addiction should not prevent healthcare providers from using opioids, though, to treat moderate to severe acute and chronic pain. Although tolerance is not as common as was once thought, it's essential to assess for increased analgesic needs in patients on long-term therapy. The healthcare team needs to evaluate and rule out other causes of increased analgesic needs, like disease progression or infection. If significant tolerance to opioids develop and it's believed that an opioid is losing its effectiveness, or if intolerable side effects are associated with escalation of the dose, then the practice of opioid rotation may be considered. Like tolerance, physical dependence is an expected physiological response to ongoing exposure to pharmacologic agents manifested by withdrawal syndrome when blood levels dropped abruptly. To avoid withdrawal, the drug should be tapered. Neuropathic pain is often not well controlled by opioid analgesics alone, and treatment is typically augmented with adjuvant therapies like amitriptyline, nortriptyline, desmopiramine, serotonin norepinephrine reuptake inhibitors, anti-seizure drugs. An example of neuropathic pain is called phantom limb syndrome, and this occurs when an arm or leg has been removed because of illness or injury, but the brain still sends pain signals from the nerves that originally carried the impulses from the missing limb. These nerves are misfiring, and this causes pain. And this kind of pain does not respond very well to painkillers. Another way to deal with this is if you look at this picture, they're using a standard 6-foot long mirror lengthwise between a patient's left leg and a residual stump on the right side, with the mirror reflecting the intact leg. So when he moves his leg, watching the movement in the mirror, and he's imagining that his missing leg is making the movements. Using mirror therapy, patients are able to get off pain medications altogether, and for many, it's brought it down to the point where it's manageable with low doses. Ethical issues with pain management. A common concern of healthcare professionals and caregivers is that providing sufficient drugs to relieve pain will precipitate the death of a terminally ill person. Nurses have a moral obligation to provide comfort and pain relief at the end of life, and the rule of double effect provides ethical justification for administering analgesics despite this possibility of hastening death. This rule states that if an unwanted consequence, like hastened death, occurs as a result of an action taken to achieve a moral good, which is pain relief, the action is justified if the nurse's intent is to relieve pain and not to hasten death. Unrelieved pain is one of the reasons that patients make requests for assisted suicide. Aggressive and adequate pain management may decrease the number of these requests. Assisted suicide is a complex issue that extends beyond pain and pain management. Although the use of placebos has declined, the use of placebos to assess or treat pain is condemned by several professional organizations.